Okay, everybody, welcome to the stroke assessment and bypass presentation. For those of you that don't recognize my voice, it's Jonathan Lovegrove. I am one of the PMH EMS education officers. So I'm just going to give you the big ticket items, stuff that we're going to review in more detail as we go through this. So number one big change is the fact that HSC is now in play and that we may be bypassing normal stroke sites in favor of HSC in certain circumstances. Number two, we're going to have an awareness of the patient's medications, as an anticoagulant may preclude those patients from going to the normal stroke sites that we would have normally transported them to. Third thing, Cincinnati stroke test is gone, and we've got a new assessment tool called LAMS. So let's go. E15A is going to be, generally, I'm going to say, the guiding document or care map that we refer to over and over here. The other G documents, they kind of fit into the E15A as branches on a tree. But the E15A, it's the central document that they all branch off of. So let's take a look at E15A. All right, so let's just jump right into this. Keep scene times to less than 20 minutes. No change there. Time is brain. What I'm going to say, and I think it's important to reference this and state that clearly, because the expectations are pretty great now in terms of running a stroke bypass call. There's a lot of assessments, they've been expanded, and there's a lot of people that you potentially have to call, including the stroke neurologist, dispatch, the emergency department, maybe even an on-call supervisor. In addition, you got to still maintain patient observations. You still have to be watching them very diligently. So lots going on with this. So why that's here in my mind is just to remind you, each of you, do that stuff en route in a moving ambulance. Do your initial assessment on scene. If they're positive to stroke, get going, get moving. The next box below, ensure ABCs and exclude hypoglycemia. So to that, I think what they're raising is the fact that we need to have an awareness of contraindications for these patients. These are not new contraindications. They are the same ones that have existed from previous versions of the stroke protocol, but I'll go through them all the same. What they really, the shortcut answer to the contraindications is, if the patient's unstable, you shouldn't be bypassing an open emergency department. And that's essentially what this says. If there's instability of the airway, breathing, or circulation, it can't be managed by available pre-hospital personnel, you need to go to an open emergency department. If the GCS is less than 4, obviously we have to treat those. If after you treat them, the patient is no longer symptomatic for stroke, then go to your local emergency department. However, on the other hand, if after treating for hypoglycemia, the patient is still symptomatic for stroke, then you need to transport to the appropriate stroke facility. If the BGL is greater than 25 millimoles, they're out. GCS less than 9 or eye opening score less than 3, contraindicated. And again, just to drive home the fact that if these are unstable patients who may be in respiratory failure, shock, or sepsis, you cannot bypass an open emergency department, and you need to go there first. The next little point here, advanced healthcare directives indicating comfort care only. I would say that you should always be following whatever direction is prescribed on an advanced healthcare directive. So whether that's for stroke, or maybe it's just showing up, and whether or not you provide analgesics for whatever reason, always follow the advanced healthcare directives. The other thing that I want to just point out and mention here, because I sometimes forget, is complete resolution of symptoms or signs prior to scene departure. So what they're saying with that, and again, not new here, But what they're saying is during your assessments and before you get en route, if those symptoms resolve before you get en route, then just go to your local emergency department. If, on the other hand, the symptoms of the stroke resolve maybe 5 minutes, maybe an hour and 5 minutes after you've departed scene, and then the symptoms go away, in those cases, continue transport to whatever stroke facility that you're going to. The next thing that changes kind of significantly is LAMS. No more. LAMS stands for Los Angeles Motor Scale Score. A couple of big changes from the Cincinnati. Number one thing that sticks out to me is there's no longer a test for speech, at least not yet. We're going to get to that in a bit, but not for LAMS. You don't have to assess for speech. The other thing that changes is the LAMS it's a scoring system. And the higher the score, the more symptomatic with stroke-like symptoms that these patients will have. So the more serious the patient with stroke-like illness, the higher their score. If we look at facial droop, one of the first things, we'll just start there because it's the first thing. Facial droop, we want to know, is it absent? So there's no facial asymmetry. Everything is fine. That's a 0. That's great. However, if we're assessing for facial droop and it is there and it's partial or complete drooping of the lower face, that score is a 1. That in itself is positive for stroke. And you just keep going through the rest of this as well. Again, the higher the score, the worse the patient is. But I just want to remind you that even a score of 1 is positive for stroke. Keep going through this document. I'm going to take you through a couple of different routes that we can go through this document. This is going to be probably what we're expecting may be the most commonly used pathway, and it's also what we currently have been doing in the past. So I just want to take you through that first. Nothing changes in relation to the onset of stroke-like symptoms. You must know absolutely when was the patient last seen well. This protocol does not work without knowing that information. First thing you see here is, can the patient arrive at a site listed in Table A, which I'm going to get to in a second, within 3.5 hours of onset? So that timeline, we already know about that timeline, so nothing new there. We actually have some stroke sites in terms of that we can transport to. So the first thing that I want to really point out to you is there is now a comprehensive stroke center. We've never had access to such a site. That is HSC. The other two categories of stroke centers or sites, they function the exact same. So primary stroke centers and telehealth stroke sites, I know that they're listed separately. In reality, they function in the exact same manner. And just to give you an example, I know for a fact that on some days, Brandon is able to offer a neurologist at the bedside, but on just as many days, they're not able to have that neurologist there. So they will use the telehealth system. The patient gets the same care at the primary stroke center and the telehealth stroke sites. So they're considering fibrinolytics at this time. And we're going to get to the comprehensive stroke center and how that really changes things in a bit. E15A. So after determining, can we arrive at a stroke site within 3.5 hours? If the answer is yes, the next place that this takes us to is we need to be aware of what the patient's medications are. Are they on an anticoagulant? So there's a table for that too. I'll come back to this here. G02.3 is going to be the document that we go to in a moment. This is the anticoagulant table. So you really have to probably take a couple of moments before you get en route to anywhere to ensure that your patient is not on these medications. In terms of how common it is or the frequency, I'm going to say that I suspect that it will be high, the number of patients that you see on these types of medications, which can potentially alter where you go. So this information, in terms of the LAMS scoring that we talked about already, and now the anticoagulants table, we're going to have laminated sheets that are available to everyone in the back of the ambulance. That's already there, already done. If you don't have access to those, or if they've disappeared already, you can still get this information off of the tablets or off of the phones. So if we're going to say the answer to our question was no, they're not on an anticoagulant, that we're going to look at is G02.3a. I'm going to simplify things here a bit. So we're going to say, is the closest stroke site in Winnipeg? Let's say no. What you're going to do is transport to the closest stroke site that we looked at on the earlier table. And if you don't know, simply ask dispatch. Ensure pre-arrival consultation with the stroke neurologist. Don't worry about it in this region. That's only something that we're going to be doing if we're going into Winnipeg. The next thing, this is not new. We've been doing it all along. We do it on actually every call that we do. Call the emergency department on scene. I guess it would have been helpful if I wrote this on here, but on scene after you've assessed and the patient is positive for a stroke. So you have to know that they have a stroke before you call the emergency department and say, we got a call, we got a call. They're not going to care, not yet. And then call the emergency department again 10 minutes prior to your arrival at their facility. Now let's look at this a little bit. Is the closest stroke site in Winnipeg? And I'm taking you down this road because number one, we need to be aware of it, but the frequency is probably going to be a lot lower. For the majority of us, Winnipeg is not going to be the closest stroke site, but for tree herns of the world, it might be. And for those of you that are doing transfers in and out of Winnipeg, if you're coming home or going into Winnipeg empty and you get attached to a stroke call, you need to have an awareness of what to do. So off we go toward Winnipeg. Will the transport duration to the city exceed 90 minutes? Let's say no. You're pretty close. You're in Portage. You have to know the LAMS score. So remember earlier I said the higher the score means the worse they are. So if it's a score of 1 or 2, most likely they just need fibrinolytics, and they can be treated with that at St. Boniface. However, if the score is higher, 3, 4, or 5, you need to go to HSC, as there may be surgical interventions that are required. You need to consult a stroke neurologist, and I'm going to go into detail as to what that requires. Excuse me. Just not at this moment. You do also need to notify the emergency department staff at that Winnipeg facility, whichever one it is that you're transporting to. Again, phone the stroke neurologist 30 minutes prior to your arrival. And on this one, I'm going to say, maybe you need to do this. After you've phoned the first time, I would simply ask the neurologist, do you want us to call you back again? Because we're pretty close, or whatever the case might be. And they may or may not require that. And again, do the same thing you do in your local regional facilities. Call HSC or St. Boniface 10 minutes out one more time. Okay, so one more way that we're going to look at this here is the transport duration to Winnipeg greater than 90 minutes. So maybe you're north of Winnipeg. Maybe Winnipegosis or somebody got up there for some reason. If you're more than 90 minutes away, but Winnipeg is still the closest, you need to contact the STARS transport physician. So you guys probably already know the way that you do that is you go through dispatch. From what we understand, and I won't make any guarantees, is that the STARS transporting physician is going to want to know your LAMS score. They're going to want to know a BGL, patient's vitals, and whatever else they ask, It's our responsibility to provide that. Once that's been done, we're going to phone the neurologist. So we still have to make those calls to the neurologist and potentially a first call to the emergency department, even though it might be a STARS transport. Back at E15A, one more time. So the next document that we're going to look at is G02.2A. And I'm going to tell you how we got, or how we're going to arrive at this point. So if we come down from the yellow box at the top there, which is keeping scene times to less than 20 minutes, we go through our contraindications. None are present. We've calculated a LAM score, whatever that might be, as long as it's greater than 0. This patient has stroke-like symptoms. They need to go to a stroke facility. The next thing that we come to is a timeline. Can we get that patient to a stroke facility within 3.5 hours from the time of onset? If the answer is no, then we need to see, can we get them to HSC with the assistance of STARS? If the answer is yes, then off we go to G02.2A. Okay, I'm going to back up again to the 3.5 hour box there. Let's say that you're in Verdun, you get to your patient, and time's not a factor, not critical at all, because you get there 10 minutes after onset of symptoms started for the stroke. So you're well within your time to be able to get to Brandon. And then the next thing you're going to do, because that's a yes now, then you check their medications and you find out, you know what, they've got atrial fibrillation, they've got some other issues, and as a result, they're on an anticoagulant. So because they're on an anticoagulant, we need to look toward HSC for our option. Again, 6 hours is our timeline. We need to get a hold of STARS, and we're going to, again, both of those different pathways take us to G02.2A, and that is to HSC right now. So off we go towards HSC. So we're going to say, will the transport duration to HSC exceed 90 minutes? And you know what? I think 99.8% of the time, the answer is yes. So let's take a look at it through that lens. You're going to contact the STARS transport physician, and that's going to be done by going through dispatch, transport as they direct. And what I would point out here, you know, this is not always going to work every time in terms of you getting a STARS intercept. I mean, they're doing other calls. They have other issues as it relates to weather and other factors. So there is a possibility that even though you need a STARS intercept, you may not be able to get one. If that is the case, what I would say is that STARS transport physician, in combination and in consultation with the neurologist, may work out alternative options for your patient that you have. And that may, in fact, including expanding the 6 hour window. So I know the protocol says they need to be at HSC within 6 hours. What I also have an awareness of is the fact that sometimes those timelines can be stretched out, but not on our call. That's on the neurologist call, and the stroke transport physician can also help you to get that accomplished if that's what your patient needs. Okay, so we've talked to STARS transport physician. We are transporting as directed. It's still up to us to be able to phone the HSC stroke neurologist. Even though we've got a helicopter coming, there's probably lots of time left. So it's a little odd, perhaps you think it is, and I thought it was at first too, for us to be calling for a STARS intercept before we even had our patient accepted in Winnipeg. Because off we go to Winnipeg, but we don't actually know that they're accepted. However, on the flip side, and that is, there's no use telling a neurologist that you're coming only to find out that, yeah, like there's no way that we're going to get from Dauphin to Winnipeg in the times, and it turns out that STARS isn't even available. So call STARS first, make that arrangement first. Next, you're going to call the neurologist. There are some things that you need to be able to tell that neurologist, and this is outlined on a document that they've put together for us, and I'm going to go over that in a minute. So number one, phone the neurologist. Do note that the neurology numbers for St. Boniface and HSC differ. Those numbers, just FYI, for those of you in PMH, those numbers have been pushed to the iPhones that are on the trucks. Brandon, you guys are in a little bit different situation, and Shiloh, I'm not exactly sure. The numbers for everybody, though, are in this document. So you don't have to go, it's not going to be impossible for you to figure out the numbers if they're not in your phones. What is important, and again, this is going to be found in the protocol itself, you have to ask to speak to the stroke neurologist on call. And the key part here is please tell the operator that this is a stroke 25 outside call. If you don't do that, you might be on hold for quite a while. So really important there. Things don't change in terms of contacting the emergency department at HSC as soon as you can. And then again, 10 minutes out from their facility. And as I mentioned earlier, do you need to phone the neurologist back? I don't know. Ask them if they want to call. Information that the neurologist is looking for. This was developed in consultation with the neurologist within Manitoba. I'm going to say that most of the information on here, it's stuff that you guys are doing anyway, so that shouldn't really be, for the most part, that much different. In terms of your charting, please put it all onto your PCR. So don't write on an extra piece of paper and attach it, or even on these documents. So I mentioned earlier that we're going to have laminated copies, and hopefully they're still on track. LAMs being on the first page, along with the anticoagulants. On the back side of that laminated copy will be this information here that you need to provide the neurologist. So really basic stuff. Age and gender. When did the stroke start? What are the symptoms that correlate with a stroke? Check the anticoagulation table. Are they on any of those? Is the patient on warfarin? And don't be surprised if your patient does know. For those that take it, they have to get it monitored pretty frequently, so there's a good chance they'll know. And if they don't know, the family may know that you've taken, and we'll get to that in a second. Advanced healthcare directives, we talked about that. A lot of this is very repetitive from things that we would already have. The neurologist just wanted to make sure that we included it. So vital signs, including initial BGL, as well as any treatments. LAMS, what's the score? Interestingly, we still do a focused neurological exam for strokes, and we assess both left and right side of the patient's body, and we still assess for speech. So that appears here. So just like in Cincinnati, normal, slurred, incomprehensible, or mute. What's their speech? Smile, arm strength, left, right, hand grip strength, left and right, grip, leg strength, left and right. Medical history. They want to know, how's this patient been recently? What's been going on? Any surgical procedures? Any injuries? Any myocardial infarctions? A little bit of error here. And or has there been any serious bleeding? They're going to want to know, has the patient had a seizure very recently? Any clotting or bleeding disorders? Any other health conditions they have? What about their medications, allergies, and when did they last eat? So again, nothing really that shocking here at all. It's just this is what they're asking for us to do. Don't be disturbed if you haven't got all the information gathered when you phone the neurologist, or don't be surprised if the neurologist asks you something that's not on this list. They have the right to ask you whatever you want, whatever they want to know. And if you don't know, find it out. Not a big deal. Even go so far as to pass the phone over to the stroke patient if they're able to speak. Or potentially, you might have that family or caregiver that's with the patient and you've transported them as well. That's a really good time to see if they can offer any assistance. And here we are back once more at E15A. So we've looked at G02.3A. We've looked at G02.2A, which is the comprehensive stroke transport. If it is the case that you have bypassed a closer facility, we're going to look at one last document, G02.18, which is the stroke bypass, and IFT override. In reality, what I really just want to point out to you, and it's simply because you need to have an awareness of this. The fact is, the contraindications for this entire protocol, and they apply on the front end from initial patient contact, those contraindications are not found until we get to this point. So just know that if you have a patient that's in shock or sepsis at the very beginning of E15A, you cannot transport those patients to a stroke facility. And I point that out because if you look at document E15A, it will tell you the contraindications are none, not quite accurate. There are a number of contraindications for the protocol of transporting for stroke, and they appear right here. And so you saw in the first slide, we talked about that. This is where I pulled them from. I'm going to move ahead here looking at, this is the backside of E15A. So we've been looking at E15A all over on the front in terms of the care map. So let's look at some of the information on the back. Some of it's important and I just want to go over it. Number one, they've got it in bold and that's for a reason. This is really important actually, and this follows really internationally held and accepted guidelines, is if you have the ability to take a family member or a bystander that's witnessed or can be helpful in terms of identifying the stroke onset or symptoms, you need to encourage those individuals to go with the patient in the ambulance. So give them a seat in the front of the ambulance, encourage them to go. Of course, that's not always going to be the case. People have things going on. They got kids to look after, etc. Chicken in the oven, who knows? If that's the case, get a cell phone number and just say, you know what? The neurologist may need to phone you. We just want you to keep the phone line open and be able to receive those calls if he or she phones. See if you can arrange for that as plan B. In terms of what are the expectations? What do you need to do? I think that's important to outline. So number one, keep your scene times to the minimum. This is not a stay and play. This is get moving. Time is brain. Continue your assessments en route, just like we discussed earlier. Perform cardiac monitoring during transport. Really critical here, you need to make sure that these patients stay oxygenated. They cannot become hypoxic. So our target saturation rate for them is 94% and above. Consider vascular access. I would say you should really strongly consider vascular access. If you're transporting a stroke patient to either a regular stroke site or to the comprehensive stroke site, they will absolutely need vascular access. So I would really strongly encourage you to obtain that. They don't tell us where or what size, take what you can get. Do a 12 lead. In relation to this here, they're saying when you are not transporting to a stroke site with chest pain or, you know what, I would just say it's never a bad idea to get a 12 lead. So if you can get them, fantastic. That's better. Next, I just want to take a look at here is, in terms of your vitals, when are you going to do them? And there's less and less rigid requirements in terms of when you need to do your vitals. It used to be, we would say every 15 minutes or whatever it was. We're saying that it's up to you. Do them as appropriate. That's when you do them. If there's been a change in patient condition in any way, reassess, get a new set of vitals. These patients are not in great shape to begin with, so you do need to monitor them and do frequent sets of vitals. At what times exactly? I'm going to say that that's up to you as providers. The only thing that may change the frequency of when you do your assessments will be not only if there's a change, but also based on whether the neurologist wants you to do something a little different. So they may say, you know what, we want you to check every 5 minutes, get a blood pressure every 5 minutes. I don't know if that's the case, but follow their direction. Otherwise, as required. This one's a gimme. but don't administer anything or allow anything by mouth. Obviously, I've gone over some of the other lesser parts of the protocol, and I would really encourage you to go back over these documents and review them in greater detail. Um, that does bring me to the end of the presentation. For those of you that are watching, and if you haven't already done it, make sure that the memos that we've got posted to the PMH website, that you mark that you've read those. That is the indicator that you are aware of the change and that you're following it. For those of you that have already taken the presentation and you're just doing it for review, I just want everybody to know that as soon as you've watched this presentation, the expectation is you are now trained and ready to be able to implement this protocol. For your phones, if you haven't already updated your own phone, whether you have the PPP app or the PAM apps, you need to be able to update those. So one last thing, unlike other changes that we've done in terms of protocol updates, there's no test that you need to do. Just click the red memo. You've already listened to me chatter on here. You're good to go. Any questions? Please don't hesitate to ask either myself, Judy, or Brian. Thank you all very much for listening in.